So now we're going to go to the first CBT session, which is this. We're going to spend more time on this session than any other single session because it has more in it, and it's really important. Let's see. The first session, ideally, would be with both the adolescent and the parents. Now, of course, you're going to have cases where that's not feasible, either because they're not all available or there's so much conflict between the adolescent and the parents that you don't want them in the room at the same time, in which case you'll have to spread this out. Or you'll have divorced parents, and you'll have to figure out what to do with the non-custodial parent. You know, on the whole, it's better to involve them if you can do that. And they are, at least in North Carolina, they are entitled to the medical record, so they need to know what's going on in the treatment. And if you're in any doubt, contact your lawyer. I mean, there are some cases, I guess, where it would make sense to exclude a non-custodial parent, but it's hard to really think of them. Yes?
Just an observation regarding medical records.
Yes.
Medical records in these cases where you've got the divorced parents.
Yeah.
I've learned over the years to be giving out we do a special contract which states that because of the divorce and the unsafe nature for the child in therapy, we need to make it a safe situation rather.
Yeah.
So the records they're agreeing not to subpoena the records on either side, that the record belongs to the child. Huh. And of course we would obey a court order from a judge or something of that sort. But it's worked every time.
Oh, that's interesting, yeah.
I've never had any issue, and I have a child-adolescent exclusive practice, a lot of post-divorce.
Yeah.
And they'll send the thing from the lawyer, they'll try.
Yeah.
And then I respond to the subpoena, and I give them a copy of that contract that we did and say, unless you send me a court order, we're not doing it.
And so both parents sign that at the beginning?
Mm-hmm.
Okay.
Because if not, I'm not going to do it. Because, you know, what do you do? And one parent says, release the records, and the other parent says, no, I don't approve of releasing the records.
Yeah, right.
And plus the child said stuff about one of the parents and all that.
Yeah,
It gets nasty.
Yeah, that's a real dilemma. Yeah. Yeah.
Well, it's a statement and a question. I mean, obviously it's better to do the treatment with the parent involvement.
Yeah.
But there's going to be times that the parents are not going to be available, they're not interested.
Right.
But then you also have the other factor of, especially when it's not involving suicidal ideation and stuff like that, it maybe more is on the dysthymic note or major depression that's not including that.
Yeah.
Where the child doesn't want the parent to be involved.
Right.
And sometimes you have that bind too because you're in a position where you want to establish that rapport, and maybe you're moving to that, but there's going to be a time period where you're going to be working only with the child and may not have the parent involvement. And can that be formulated, with this and kind of leaving that hanging on the end?
Yeah, we
to
had
maybe
cases like that in the study, yeah. We had all kinds of cases in this study. You wouldn't believe some of them. I mean, we had kids that disappeared for weeks at a time. They were homeless, or their parents lost their jobs, or the kid didn't want the parent involved, and then what do you do? Now, so the way I handle that is, it does depend on, I guess you already addressed this, it depends on whether there's risk. I am not going to see a kid who's suicidal without parental involvement. It's just not going to happen. I'm not going to see a substance abuser without urine screens. I'm just not going to do it because they're going to get me into a trap and they're going to play me off against the authority figures. And, I learned this when I was like 30, right? Because when I was 30, I was still identifying with adolescents, By the time I was 31, I was over that, So I would take a kid into treatment under those conditions as long as there wasn't a safety issue and as long as I had permission to contact the parent if I had concerns. I wouldn't agree to see them and have no contact with the parents. I would agree to see them if without maybe without having regular sessions or this kind of preferred sessions with the parents. What do you think?
Well, we all work in the school system.
Yeah.
And one thing is finding the parents. That's one thing.
Yeah.
But then there's another thing. If the child does not want parent contact and there's no risk, we we risk losing the contact with the child
Yeah.
and the connection with the child by superseding that. So most of us, will not contact the parent until the child is ready to do so. Now, obviously, we know that it's better to have the families
Yeah.
involved, and we encourage that and we move towards that. And it may be just telephone contact, or it may be, like you said, getting
Yeah.
to the point where they're more involved and more directly involved.
Yeah. So you're seeing the kid in a school,
In a
right?
school setting,
that's-
right.
I've
So we
never-
have time
that's different,
constraints and
yeah.
then also
Yeah,
have
that's
those
different.
barriers.
Now,
same
the
with
only
the
thing I would
substance
say
abuse.
about that is, from the point of view of a parent, how does a parent feel if they find out that their
Mm-hmm.
kid's been seeing somebody without their knowledge for something like depression? That's a little dicey,
Yeah, and ongoing, we don't do the long-term treatment. I mean, if
Okay.
anything, we do it in group settings.
Right.
And the parents are always advised of group involvement.
So they're told about it.
Yes, well,
Okay.
in writing, so.
Yeah. They may or may
Right.
not read it, but they-
Exactly.
Yeah.
Exactly.
Right.
But, they're told that way.
Uh-huh.
But generally, we don't have the ability to do the long-term services anyway, so a lot of it is brief, doing more of that assessment
Yeah.
portion that you're referring to, and either
Right.
addressing it in a group setting or
Yeah,
referring out.
referring out.
And if we
Okay.
refer out, then obviously we need some type of parent contact and authorization.
Okay.
So,
Yeah. Okay. Anybody else want to comment on that? I don't work in a school, so although I do consult with people who do, but yeah.
I had an interesting experience working in an SED center. I don't know if you have SED centers in various places, but a school for emotionally disturbed kids
Yeah.
in the public school district. It's a long time ago. But my memory is that, there was one thing nice about that setting in that the child or adolescent would be getting into a conflict. You could pull them right into your office and process and all. That was wonderful. The other part of it was the frustration of not having parent involvement and sending them back home.
Yeah.
And, there's obviously things going on at home. And I have also found in my clinical practice, now in private practice, that there's never been a situation where I can't get the child at some point. If I feel that the parents need to know about something, I started out setting up the boundaries that the child gets to determine confidentiality, and then I tell the parent and the child. But, there's a limit to this. If it's certain, if you tell me you went to a party last Friday night and somebody passed around some weed and you puffed it, I'm not calling your mom on the phone right away.
Right.
On the other hand, somebody's shooting up something daily, I say, we're going to have to get the parents around. And I've always been able to get them to come in. I think we all can
Yeah.
do that work.
Yeah. So this is why this first session is so important, because this is where you have to set up all those contracts, including the safety contract and the confidentiality agreement, and it takes time, and often it takes more than 1 hour. And you have to deal with all these realities that, make it impossible to do it ideally. So let's just kind of step through it, and you'll see how we tried to handle it in the study. The first session includes the rationale for treatment. So part of it is to give both the kid and the parents an explanation of what you just did in a case formulation. Yes, this child has depression, and these are some of the things we think are contributing to it. You'll see this on a videotape where I did this. And goal setting. And this doesn't have to be at the beginning of the session, but sometimes sometime before the session ends, you want to get from the child and probably from the parents, what are their goals for treatment? Because you're going to keep coming back to this. This anchors the treatment. And you saw, I think you might have picked up on this in one of the talks yesterday. I forget which one it was, though. But the goal setting thing seems to be an essential part of successful treatment in clinical trials for various problems, including depression. It gives the kid something to aim for, and it gives you something to aim for with them. The second bullet here is psychoeducation about depression and about CBT. You have to explain to them what CBT is and how it works. This session is distinct from all subsequent sessions, partly because ideally you have both the kid and the parents there, and partly because you're doing an awful lot of talking in this session, which is different from later sessions. And in the TADS manual, you'll see that future psychoeducation sessions are for parents, just parent psychoeducation. The child psychoeducation is in little bits in each session, but there are entire sessions devoted to explaining the treatment to the parents as the kids are going through it. I don't know. I'm not convinced this is the best way to do it. I said yesterday, we don't know what to do with parents. We just don't have any evidence on what's the best way to do it. So you have to use your clinical judgment. But this is the way we wrote it in the manual. Okay, so the session moves from the therapist introducing themselves if they haven't already done the evaluation, and then reviewing the presenting problem. You want to convey in this session that treatment is a collaboration. This is extremely important. It comes out of the Beck model, but it also comes out of traditional psychotherapy, Rogerian therapy, psychoanalytic psychotherapy, any psychotherapy. The patient or client, if you want to call them client, has to work with you on the goals. The collaboration means that at least some percentage of the adolescent is cooperating with you. You can probably live with 10%, right? But you have to have some collaboration, and then the parents also are part of the team. You explain in this session the CBT model of depression, which is what we just talked about, the triangle, thoughts, feelings, and emotions, and the model of CBT. And then it's going to focus on behavior and cognition. You say for the first and not the last time here that you're going to learn skills and that this takes time and that it takes practice. We used an analogy that Paul Rohde came up with in TADS that we're going to give you tools for your backpack to carry around so you can cope with problems. So we're going to give you different tools or skills in the treatment. You'll be able to leave the treatment with new skills, and when you face challenges, you'll be able to use these tools. And eventually, you will then become your own therapist. You won't have to be in therapy for the rest of your life. You'll learn these skills, and you'll be able to apply them. Okay? The parents have a role in this model. Now, I'll have to tell you, this took us a long time to think through, so I don't want to gloss over it too much, because this gets into the whole issue of what's family therapy, what's individual therapy, where do the parents fit in, okay? So the model I'm going over with you, the TAD-CBT, is not a family therapy model. You know, you're not working on family systems issues. As you could do that with other models, obviously. You could say, well, this kid's depressed because of dynamics going on in the family, and I'm going to bring the whole family in, and we're going to work on family problems. That's a respectable, reasonable thing to do, but it isn't what we did in here. Instead, we use the idea of a team, that the adolescent, the parents, and the therapist are part of a team, and the team's job is to take aim at the adolescent's depression and help her or him to overcome that. So the depression is the quote-unquote target of the treatment. Work with the parents might include help in responding to their adolescent's depression. You're like, what do they do when Mary doesn't want to go out and the parents are frustrated and upset? What should they do? Secondly, it might include increasing positive things in the family and decreasing negative communication or family conflict. What's missing from this list by intention is any idea that the parents are to blame for the depression, or that the kid's to blame for the depression. I mean, would you blame somebody for diabetes? I mean, you could, I guess. I mean, if they eat too much and they develop diabetes during their life, I mean, I guess you could say, well, you know, they should have done something differently. But what good is that going to do? I mean, you have to help them then to cope and change their diet and manage it, right? So sure, the parents might have done something, or the kid might have done something that contributed to the depression, but that is not where you're going to focus. And you want to avoid blame. I mean, that's one of the main reasons parents don't want to come in. They think you're going to blame them. Especially fathers, right? It's notoriously hard to get a lot of fathers into treatment because they feel like you're going to blame them. So the idea of the team and the collaboration is really critical, and keeping the target on the depression. That's what we're trying to change. Goals for the treatment. Now, how do you ask kids about their goals? This is in the manual, but I just summarized it here on the slide. What would you like to get out of this treatment? Or how, if things could be different and better, what would they be like? What would you like your life to be like 3 or 6 months from now? Are there ways you would like things to be better at home or with friends or at school? These are all probes you can use to help the kid generate goals. Mark Reinecke was the one who contributed a lot of these ideas to our group. You probably use one or more of these already. Right? And then the rules of the road. What are the rules? So this is the way we did it, and it's probably similar to the way you do it, but maybe a little different. And this is all spelled out in the manual. So confidentiality is very much like what you were saying earlier. When you talk to me about things in individual sessions, I am not going to disclose to your parents what you said, okay? I will talk with your parents about the skills that you're learning. And if I feel like something you said it would be good to share that with your parents, I'll encourage you to do that. There are going to be certain things that I have to report to you know all this stuff. The things you have to report to the parents, right? Suicidal stuff, danger. We use the rule of dangerousness. If it's dangerous, we got to report it. So that shooting up drugs would be dangerous, right? Taking a puff on marijuana is not dangerous, not going to be reported. Those are the main things, all right? Contacts between sessions. What if the parent calls me, what if I have a session on Wednesday and the parent calls me on Tuesday and says, Johnny's been doing so-and-so, and I really want you to address this in treatment. Have you ever had this happen? I thought maybe. The way the principle we used was that we tell the child that the parent called. So you always want to be transparent and not kind of sneaky. I can't say that over my entire career I've always abided by this principle, but for the most part, I try to be transparent so that they don't think I'm pulling one over on them. Attendance is important, and the schedule, we review the schedule. Okay. And then the safety plan. The safety plan is part of the first session. And in TADS, I didn't get into this yesterday, but we did not take in highly suicidal kids. So if they had a recent suicide attempt or a recent hospitalization for suicide, they were not taken into the trial. The reason for that was that we had that placebo arm, and we didn't think it was right to take highly suicidal kids into a placebo arm. So the TADS manual is written for kids that are not highly suicidal. There's another manual that's for suicidal kids called Tassa Treatment for Adolescent Suicide Attempters, which is not yet available, but it's still being worked on. Nevertheless, a lot of suicidal kids have a history of a lot of depressed kids have a history of suicidal thoughts, urges, or actions. So you go through with them the time when they were most suicidal and review with them what helped them to pull out of that. You emphasize with them the importance of time, suicidal urges do pass. If you can kind of surf it and wait it out, it will get better. And then you come up with an action plan for what to do if this happens again. Who to call, people to contact, you give them phone numbers to contact of your clinic or your practice, the local emergency room, and everybody has to agree on this plan, including the parents, okay? So I don't want to get myself into a corner with an adolescent who's going to become suicidal and the parents have no clue about this. Not a good idea, okay? Okay, so that is the content of the first session. Now, do you have any questions about this? I have a video that I'll show you in a minute going through some of it, but any questions about it before we do that?
I'm just curious. I know you mentioned it, and obviously it's certainly emphasized in the Beck model the importance of collaboration. At least in my limited experience, I think that's the biggest obstacle that I encounter, and especially with adolescents.
Yep.
So, and if there needs to obviously goal setting is critical.
Mm-hmm.
I'm just curious if that's something that you, when you encounter that initial wall, so to speak, I'm not here to talk to you. I don't, my parents are forcing me to
Right.
be here. Or even if they're, even if they just are not expressive. And
Mm-hmm.
so will you put that to the side, so to speak, and try to, and a lot of times, even once you've established rapport, it's
Yeah.
it's so difficult to get them actively involved in the therapeutic
Yeah,
process. So,
absolutely. I mean, I'll just wait on all the other parts of the session if I have to and work on the rapport. And usually what I do is I try to go with their affect. I mean, if they look like they're angry, I'll comment that, they don't look like they're real crazy about being here, or, their parent, you must feel like your parents dragged you in. I don't ever forget Carl Rogers, man. He was the one, number one guy. Accept, reflect, and clarify. You can do all the CBT in the world, but if you forget Carl, you're doomed to failure. And I might spend, quite a bit of the session on that. Now, I think that in 34 years, I can only recall one adolescent who totally succeeded in refusing to say anything to me. He sat through the whole hour and didn't say anything. And I really lost, But depressed kids are usually capable of making a connection in a while. But it is really, what you're bringing up is critically important. Do not be dictated to by a manual. If you feel like you need to do more work on the engagement, just do that. I think the only thing you have to do in the first session, you have to have a safety plan, at least the beginning of a safety plan, and, some relationship with the kid. That's basically it, yeah. But yeah, they can drive you crazy. I mean, they're masters at that. At least in the United States. I don't know if this is true all over the world. I've kind of become interested in this question. Is this just something in the American culture that we kind of develop this thing about autonomy and our kids are all focused on autonomy? I don't know. It may be a cultural thing, but certainly in our country, this is a common issue. And in the treatment of adolescents, it's a common issue. So basically, you're right. What you're doing is the right thing. Go with the relationship. Okay, now let's see what we're doing on time here. Oh, okay. So we probably have time to look at some of this tape. Could we look at the? This is a first session. Again, this is one of my graduate. It's the same graduate student. And what I'm trying to do here is psychoeducation about depression and treatment. Hi there.
Hi.
So today we're gonna start the treatment program for your depression. Okay, we talked about the symptoms that you had last time, and I got a sense of how you've been feeling in the last few weeks. And now we're gonna meet to try to treat that. Okay.
Okay.
And I mentioned to you that. I think what you're experiencing is called depression, but I don't know what that means to you. When I say that, what do you think of?
I haven't been feeling well, sad.
Okay, so sad, okay. And did you ever feel sad before where it didn't kind of like hang around all the time?
Yeah.
What do you remember about that?
I don't know, just like here and there, like everyone.
Okay. Remember anything that made you feel sad in the past?
I guess when my dog died.
Yeah, that's a good example. I mean, pretty much anybody would feel that way when their dog died, right? So when we talk about depression, it's not the same as regular sadness, okay? Although, it can involve feeling sad or having other negative feelings. But they go on for a long time, or they feel a lot worse than regular sadness, okay? So that's pretty much what we mean by depression, So I wanted to show this to you and also your parents who are here again. Just to explain this, and you can keep this, all right? It summarizes what we mean by depression. And you can see at the top, the first thing about it is what we were just talking about, that everybody feels sad or bored sometimes, but when it goes on for a long time, or it feels much worse than usual, that's when we call it depression, okay? And then at the bottom there, you can see the list of, and it goes on to the next page too, the list of some of the symptoms of depression. And we've talked about this already in the interviews we did last week, but you can see there all the possible symptoms. And which ones do you think you have? Like under emotions, which emotions do you feel mostly?
Sad and bored.
Sad and bored, okay. So you haven't been feeling guilty a lot about stuff or anything, okay?
No.
And how about in the thinking part? What kinds of thoughts have you had that you noticed there?
Like we said, I can't concentrate.
Right.
I'm losing interest. I haven't done the things I used to.
Mm-hmm.
I guess not really self-blame, but just thoughts that like I'm not good enough.
Okay, so you get that thought. You get that in school or where?
Yeah, school.
Okay. Anywhere else?
Mostly just school.
Okay. Okay. And then if we look down on behavior, what changes in your behavior have you noticed?
I guess I didn't mean to, but I guess avoiding people
Mm-hmm.
since I've just been home and sleeping.
Mm-hmm.
So I guess isolating too,
Yeah.
slow moving.
You find yourself moving more slowly?
Yeah,
Okay.
just always tired.
Okay. Do you think other people would say you move more slowly, or is it just more of a feeling of that?
No one's mentioned it.
No
I
one's
just feel
mentioned
it.
it. Okay. Okay. And how about the last group, the biological symptoms? Which ones of those have you had?
Sleeping a lot. I have a loss of appetite, I guess. I'm
Right.
tired.
Okay. All right. So that's what we mean by depression. Now, the good news about depression is that there are treatments that work. And you're going to get one of those treatments in this program. Okay. In fact, you're going to get two of those treatments in this program, which you're going to have both medicine and psychotherapy. Okay. Do you have any questions about the depression before we go to the next part?
I guess not.
Do you have any sense of how you got depressed?
No, and that's what I was gonna say, is that if I don't know how I got there, how are we gonna stop it from happening again?
Mm-hmm. That's a good question. We'll have to figure out, as we go along, what's contributing to it. You did mention that you often feel like you're not good enough. Is that what it was? Did anything happen that kind of triggered off that thought here when you got depressed?
I guess when I started getting lower grades.
Mm-hmm. Okay. Anything happen over here on this other page? You can see there's some of the more common causes. Does any of them seem to be true for you? Take a few minutes to read it over.
I guess the way of thinking about things.
Mm-hmm.
I'm not doing as well in school.
When did you first become depressed?
I guess a couple of months ago.
Mm-hmm. What was happening then?
This is the end of the semester, so I started getting my grades.
Mm-hmm.
I guess I focused on that, but
Mm-hmm.
I mean, I was feeling sad and unfocused before that, which is
Even
part of
before
why
that.
I didn't
Oh,
get the
okay.
good grades.
So it wasn't just the grade.
I guess not.
Right. Was anything going on with friends or boyfriends or family that was bothering you?
I don't know, maybe.
Not sure, but maybe. So that's something we could look into. I think we should try to figure out what was leading to it. Okay. So let me show you this to start to explain how the treatment works. And you can keep this, okay, you can take this home. But this is the way we think about the psychotherapy for depression, okay? So you're going to get some medication which will help with some of the biological part of the depression. It should help you with your energy, okay, and kind of get you moving again a little bit, okay? And Dr. March will tell you about how that works, okay? For the psychotherapy, here's the way we think about it. We think about everyone as having 3 parts to their personality, okay? Thoughts, emotions, and behaviors, okay? And these 3 parts kind of work together. So, what sports did you say you played growing up?
Softball.
Softball. So when you were playing softball, did your team win some games?
Yeah.
And how did you feel then?
Good.
Felt good, okay. And do you remember making any good plays or getting any good hits? Some, okay. So how did you feel when you made a hit?
Good.
Okay, so that's an example of how your behavior and your feelings work together, okay? So you get a hit in softball and you feel good, okay? Now if you strike out, you usually feel bad, right?
Yeah.
Okay, so behavior affects the way we feel, okay? And now what is the value of psychoeducation? Why do it? What does it do for the patient?
Well, I think a lot of times they all blame themselves, so
Yeah,
educates them that this is a disorder that is
yeah.
not necessarily.
It gives them an explanation for a disorder that is not a self-blaming thing, and it hopefully it demystifies this a little bit. I mean, often people are not sure why they're having this experience. So when you start to kind of put it on the table, so to speak, and look at it and explain what are some common reasons, and then they can connect to that, it takes away some of the mystery. Okay?
It also prepares for that collaborative work that you do.
Right. If you do the psychoeducation in a collaborative way, then it sets the stage for collaboration on the rest of the treatment, right? Okay, so there is a big emphasis in CBT on psychoeducation and collaboration. But if you do it in a way that's too didactic, which I think I verged on here, but hopefully didn't fall into totally. If you do it in a way that's too didactic or too slow, it slows down the treatment and it's too much like school. Okay, so you want to try to make it a dialogue that's active. All right, now the triangle is the thing that you use to explain the connection between thoughts, moods, and feeling, thoughts, moods, and behavior. And it's also something you're going to come back to as you go through treatment. So when you get to behavioral activation or increasing pleasant activities, you explain to the kid that this is a way to change behavior in such a way that it's going to make you feel better. When you get to cognitive restructuring, you say this is a way that we're going to work to change thoughts to help you to feel better. So you keep coming back to this triangle, which is this is from Lewinson's work. It's a very simple, kind of elegant way to explain CBT that is not complicated, okay? All right, what other observations or questions do you have about this first session? It's almost lunchtime. That's my thought. You know, automatic thought. You know. All right. The first session is the longest, has the most in it. Often takes more than 1 hour. We're going to go after lunch. We're going to go through several other sessions in the early part of treatment, and we'll cover mood monitoring, increasing pleasant activities, and problem solving. Okay. And we may cover other things depending on what you want to cover. Any other questions or comments before we break?
There's one thing, at one point, the person said that I felt guilty. So, the way you diverted it and directed her towards possible future action, I thought that that was good
Mm-hmm.
you don't want to get the person get into the trap of that yes, I was guilty, so actually this is more bad.
Right, right,
Yeah,
right.
you said, okay, what could be
Yeah.
possible future actions?
Right,
and
right.
overall cause and things
Yeah.
like that. So in a way, that was something like I noticed that it was very tricky, but good.
Yeah, it is tricky because you don't want to go too fast beyond their feeling. If they'll get the sense that this guy didn't hear me, you know. But you don't want to get them mired down in a negative affect so that it's like hopeless. And one of the studies that I read about in graduate school, which I don't know how old this study was. It was called Super Shrink. Anybody ever hear of this study? The author's name was Ricks. And he went into a child guidance clinic and he looked at the records of 2 therapists. And somehow he had measures of outcome. And he looked and he found out that these 2 therapists had dramatically different outcomes working in the same clinic. One of them often had positive outcomes, and the other one had primarily negative outcomes. So then he looked back at their chart notes. Oh, this was back in the day when chart notes were really long, and it was driven mostly by psychoanalytic theory. And I can remember social workers I worked with who could seem to be able to recall the entire session and write it down. I could never do this, but they were long notes like that. And he found out that the difference between the 2 therapists in their therapeutic process was that the one who had the negative outcomes spent a lot of time on negative affect. And why do you feel so bad? And why do you feel so guilty? And why do you feel so anxious? And he kind of seemed to be putting the kids into a worse state by constantly harping on the negative. Whereas the other guy, he did some of that, but he also tried to get it into a more positive frame. And that was a very influential paper for me as a graduate student. I thought, wow, this is really something. So, yeah, you want to try to keep the hopefulness in there because otherwise they get mired down. But you don't want to discount their negative affect too quickly by just jumping over it and say, well, what can we do about that? So that's a tricky part, I think. And now, what is the value of psychoeducation? Why do it? What does it do for the patient?
Well, I think a lot of times they don't blame themselves, so
Yeah,
educates them that this is a disorder that is
yeah.
not necessarily.
It gives them an explanation for a disorder that is not a self-blaming thing, and it hopefully it demystifies this a little bit. I mean, often people are not sure why they're having this experience. So when you start to kind of put it on the table, so to speak, and look at it and explain what are some common reasons, and then they can connect to that, it takes away some of the mystery. Okay?
It also prepares for that collaborative work that you
Right. If you do the psychoeducation in a collaborative way, then it sets the stage for collaboration on the rest of the treatment, right? Okay, so there is a big emphasis in CBT on psychoeducation and collaboration. But if you do it in a way that's too didactic, which I think I verged on here, but hopefully didn't fall into totally. If you do it in a way that's too didactic or too slow, it slows down the treatment and it's too much like school. Okay, so you want to try to make it a dialogue that's active. All right, now the triangle is the thing that you use to explain the connection between thoughts, moods, and feeling, thoughts, moods, and behavior. And it's also something you're going to come back to as you go through treatment. So when you get to behavioral activation or increasing pleasant activities, you explain to the kid that this is a way to change behavior in such a way that it's going to make you feel better. When you get to cognitive restructuring, you say this is a way that we're going to work to change thoughts to help you to feel better. So you keep coming back to this triangle, which is this is from Lewinson's work. It's a very simple, kind of elegant way to explain CBT that is not complicated. Okay? All right, what other observations or questions do you have about this first session? almost lunchtime. That's my thought. You know, it's automatic thought. You know. All right, the first session is the longest, has the most in it, often takes more than 1 hour. We're going to go, after lunch, we're going to go through several other sessions in the early part of treatment, and we'll cover mood monitoring, increasing pleasant activities, and problem solving, okay? And we may cover other things depending on what you want to cover. Anyway, let's go to the second session called mood monitoring. So this is really the first skill. Remember we talked about skills or tools in the backpack? This is the first one. And it's very simple. It is to help the kids to become aware of how their mood changes or fluctuates over time, either just on its own or in reaction to things that they're doing or thoughts that they're having. So I don't see any way that you could really do CBT without doing this in some sense. I mean, you have to help people understand how they're feeling and what's affecting their feelings. So we included this as a required module that everybody would get. It doesn't take long for most kids. You can probably do it in 10 minutes. In the context of a session, but it does take a while to apply it during the week, and it's followed up in the session by the first of the homework assignments, okay? So for this, there is a handout which is not in the package of handouts that I gave you, but you can see it if you go to the back of the slides. The very last page of slides is page 4 of the final section. I have the slides divided into 7 sections. The last section only has 4 pages, right? Now, if you go to the section before that, and you find the next page 4, you'll see this emotions thermometer, okay? Got it? So to do the mood monitoring, we have this handout and then a schedule that's used during the week. So this is the first part. So you take out this kind of unlabeled mood monitor. It just has, actually, if you see the thing on paper, it goes all the way from 0 to 10. I think the slide only goes from 3 to 10. And the idea here is to ask kids about times when they felt good, first of all. And a 10 would be the best they've ever felt. So if they can think of a time in their life when they felt really happy, that would be a 10. And you, after you elicit this from them, you write down next to the 10 the event that they tell you was connected with feeling really good. So that's your top feeling, your best feeling. And then you might write down next to the 0, what's the worst you can recall ever feeling in your life? What was the situation? Okay? And then fill in 2 or 3 other numbers along the way so that they get the idea that there's sometimes when they feel pretty good but not ecstatic, and there's sometimes when they feel pretty bad but not terrible. And this will fluctuate over time. So the questions I have up here on the slide are just examples of probes that you can use during sessions. How have you been feeling in the past few days or the past week? What situations have come up where you felt bad? How about times when you felt better or felt good? Okay. So you fill this out with them during a session, and then this is what's called the visual thermometer, and you fill out points along the thermometer from 0 to 10. And then there's a second handout which is in the handouts that I gave you, called Mood Monitor. It's just a daily calendar, Sunday, Monday, Tuesday, Wednesday, etc. And then it has morning, afternoon, and evening along the top of it, okay? And this is the first homework that gets assigned during the CBT. So you ask the teenager to take this mood monitor, this calendar with them, and fill it out each day, and try to put down in each day something that happened during the morning, during the afternoon, or during the evening, and how they felt about it on using the 0 to 10 scale, okay? Pretty simple, right? Now, this is a homework assignment, so it raises the question immediately of, do you want to expect your patients to do homework? And I can tell you that we had many arguments about this in the project. We had some people who thought this was totally futile and that no adolescent would be caught dead doing homework for psychotherapy. It's hard enough to get them to do their math. And others who felt that it was absolutely essential, okay? And others who felt that we shouldn't call it homework, we should call it something else, on the assumption that if we didn't call it homework, they wouldn't notice that it was homework. At any rate, our position was that we would try to get kids to do homework, and that it was consistent with the model. I mean, that you're going to learn skills, so you have to practice the skills, so you got to do them between sessions, and you're actually going to learn a lot more between sessions than you are in sessions. So, given all that, what I'd like you to do for a moment is think about how you would help a kid to get this done. What would you do in session to prepare them to do it, to actually do it during the week, other than tell them to do it? How do you get people to do homework? What do you have to do to make it more likely that they'll actually do it? Huh? You could offer a reward. You could build in some kind of a reward. What might that be for? That's right, yes. Let's get down to the basics, right. We had one therapist in Nebraska who had a huge candy bowl on her desk, and that's what she did. She just used that, you know, and that would reinforce them for doing the homework. It worked pretty well. Yeah.
I work with children, and I give them a little baggie. I have baggies for boys and baggies for girls,
Uh-huh.
and I give them that with stickers. So
Okay.
I want them to use that, and
Right.
I make their own charts, behavioral charts.
Right.
And I send them home
Mm-hmm.
homework,
Mm-hmm.
and they come back, and it has been working for me.
Okay, good.
So I
So-
give them the baggie and the stickers, so they're all excited.
That's good. Yeah, that's really good stuff with kids. They love that stuff. Yeah, it's good. Yes.
Sometimes besides rewards, just talking about the practicalities of it.
Right.
When do you think might be a good time
Right.
to write this down? How
Right.
are you going to be able to remember it?
Right.
You know, what kind of things are usually good times in your day? What
Right.
kind of times- Just talking about
Yeah.
that is often enough to help them get some.
Get it done. So are you going to do it, are you going to carry this with you during the day and do it during the day? Or are you going to
Leave it by your computer.
leave it by your computer at home? Or are you going to put it in your bedroom? Or where are you going to do it? Yes.
Some of this stuff may be applicable to put on an iPhone or a smartphone
Yes.
of some kind.
Yes.
Some of these kids are technologically
Right.
oriented, and they might like clicking on something.
Yeah, they might love that. So, you know, let them guide you in these matters in which they are more expert than you are, and see if that'll help them to do it. But it's really important to help them prepare to do the homework by kind of asking about when they're going to do it and where they're going to do it and what would be a convenient time, and, you know, the question of whether they'd like to carry it with them or leave it at home. Some people are too embarrassed to carry it with them. They'd rather leave it at home. Other people find it easier if they carry it with them, then they can just do it right on the spot, okay? I also do tell them that there is some evidence that if people do the homework, they do get better faster. There's a lot of evidence in the adult literature, and there's a little bit of evidence in the TAD study. It hasn't been published yet, But there is some evidence that kids who, at least the kids in the CBT alone condition, if they did the homework, they did tend to get better more than those who didn't do the homework. So we do know that from the study. So you might ask yourself, you might not, but you might ask yourself, well, how often do they actually do it? So this is kind of easy to remember. We found out that in 75% of sessions, the therapist asked the kid to do a homework. And in 75% of the time that they were asked, they did it. So it's 50% overall, 75 times 75, right? Which isn't too bad. You know, I think that's pretty decent for adolescents. And part of it was that not all sessions required a homework, so you don't really expect, I mean, you don't give a homework after session 1. And there are a couple other sessions where it doesn't lend itself to a homework. But I think it was pretty decent that the therapist assigned it 75% of the time, and really pretty impressive that the kids did, now I don't mean they did everything. They did something 75% of the time, okay?
There could be some negative schema, some negative cognition associated with not being able to do it.
Right.
That can be addressed as
That's right. That can be addressed when you come back in. Everything is used for learning. So if they come back in and they say they haven't done it, your task then is to use that as information to learn about what's going on, like what got in the way. And was it a thought? You know, was it a thought that, you know, I have to do this perfectly or it's no good, or, you know, I can't let anybody know that I have this problem, so I have to hide it. You know, you want to see what the thoughts were. Or maybe it was too hard. Maybe it was too hard an assignment, so you have to make it easier. So there's a lot of material in Beck's work on depression, even the first book, Cognitive Therapy for Depression, or Cognitive Therapy of Depression, I guess it's called, where he talks about how to make it more likely that people will do homework and looking for reasons that they don't do it and then problem solving around that, okay? All right, now, what happens when you give somebody this kind of an assignment and they fill it out, at least they fill some of it out, and they notice that there's more than one number showing up during the week? What are you telling them? Yeah, what's the good news? You're not constantly at the bottom of the thermometer, okay? You may have thought when you came in that you were, but it looks at, when you actually look at the evidence, there's some fluctuation in your mood. And it's tied to things that you wrote down on here. So if I go out with my friends after school, play basketball with my friends after school, I feel better. You may notice that all the times when they feel bad are when they're home, and all the times they feel good are when they're at school, or vice versa. Okay? So you're getting, right away, you're getting across to them the idea that mood fluctuates and it depends on what they're doing and to some extent what they're thinking. So this is called the Daily Mood Monitor. Ann Simmons is the person who came up with this for TADS. She's one of the psychologists at Oregon, although she just moved to Notre Dame. Okay, the third session in the manual, I think it's an optional set. I think of it as an optional session, although it wasn't optional during the study. But I think it was a bit of a waste of time, and I think it was one of the reasons that the response was slow. We had a whole session on learning how to set goals. Now, I think it should be optional. I think if you feel like the kid that you're working with doesn't know how to set goals, do it, use it. But if you think that the child does know how to set goals, I would just go over this quickly, or not even get into it, okay? So let's try this at your seat. If you would just turn to the person next to you, and one of you be the therapist and the other one be the kid. And if you have an odd number of people, which it looks like every single table does, wow, then somebody can just be the observer. But what I'd like you to do is to practice with your adolescent patient setting some goals, and then as you being the therapist, you pay attention to those goals and see if they seem like they're well-defined enough that you can actually make progress on them and tell if you're making progress. So just work on that for a couple minutes, okay? And then we'll talk about it. Understand? 151, okay. So-
Well, you could just say it's like if they use social networks, it's like your status on Facebook. So what's happening in my
All right, so let's see how people are doing on goals. The question here is, how did the role play go with the kids setting goals, and what did you think of their goals, and do you think their goals need to be tailored or just accepted as first face value, or what? Okay, all right, so can we get somebody volunteer to talk about a role play? Okay.
Because it was a sudden start, in a brief moment, we had to just assume that we have a problem and we are just getting ahead, and because we want to practice goal setting. So the problem with the adolescent here was that the loss of joy and energy. But I tried to make it an explicit as much as I could. So what does she mean by not having joy, and how this not having joy and energy is affecting. So the effect was into relationship and not being able to get up in the morning, and not being able to decide to go out with friends. And then when we go trying to understand what does all this mean, operationally defining all that from her perspective, it was that grades are being affected as well. And feeling bad and tired. So where we were reaching right now is that the focus, the goal would be to concentrate so that the grades could get better, and then some aspect of emotion as well, because the joys are not there. So the joys, feeling pleasure again, going out with friends again, improving the relationship with friends and parents, and working on grades.
All right, so everybody heard that. Now, you can see in that example how you have to kind of narrow things down, right? I mean, people are faced with large concerns, and if you're going to set goals, you have to work with them to get them narrow so that you can, you can see if you and they can see if they're making progress on them. So if you just stayed at the level of, well, I want to feel better, that wouldn't give you much to work with, right? I mean, you have to get more specific than that. So you got more specific than that, and you talked about, well, in school you talked about concentrating more, which you could even break down further in terms of getting, setting aside time to do schoolwork, something like that. You talked about the social part, like going out with friends. Okay, so that's more specific. You can measure during a week how many times somebody goes out with their friends, if at all, right? Okay, so that's a good example of how you have to make it concrete and observable. Okay. All right. Any other comments on this example? All right, well, let's move to another one. Do you guys want to talk about one of yours? Are you willing to talk about one of yours?
No, but I will give that.
You want to give the other one? The other thing? Yeah. Yeah, this is a good suggestion.
Just an idea that I had. I work with a lot of teenagers, so I was thinking that the mood monitoring could be almost like a status on Facebook. How they put in what's going on and how they feel. And you could kind of relate it to that as it relates to the things that they do naturally on a daily basis.
That's a good idea. Okay, now, you could even, you should never feel constrained by the manual or the handouts. You can make up a handout that you like. If you want to make up a handout that looks more like a Facebook page, do it, right? So that idea is cool about what you're doing and how you feel about it and your status on Facebook. Right? Okay. Other examples of goals? Somebody else want to give a goal setting? Let's go over here to this table, see what kind of goals. And don't think you have to do this right, because if you do it right, I have nothing to say. I'm out of luck, all right? So give me some example of what you came up with. Okay.
So she was being mildly oppositional, not much, but that she was still here because her parents were making her be here. And our goal was to get them off the back, but we had to figure out what does that mean. Well, they were sort of thought you were here because you were depressed, and what are they seeing at home that maybe makes them think you're depressed? And then we got down to, well, I'm not going around with as much of a smile on my face. I'm not seeing friends as much, and I'm not cleaning up my room. And I said, so if you were, going out with friends and putting the smile on your face, dropping the other one a little bit more, that would probably make them feel you're doing better. And we finally got some agreement, and then we could begin to have to break that down a little bit more. How are we going to do that even though you don't feel like it? But
That's a perfect example of, sorry. Yeah, sorry. I'll say something anyway. That's a good example of how to get it, again, from the vague and even different. I mean, that started out with a totally different point of departure, right? I mean, I don't want to be here, basically. My parents want me to be here. So I'm sure none of you have ever used this goal of getting the parents off the back, right? Nobody's ever done that one before, right? Especially with substance abusers. The goal of getting the parents off the back is a great goal. And what do you have to do to get there? And so you broke it down into a few social things, and you could have gone with the room, but that's probably a little dicey at the beginning of treatment. Okay, so you want it to be something that they can buy into and feel success about. Okay. All right, let's try a couple others. How about over here? You got a goal that you worked on? Anybody?
I was thinking more of the initial reason why she thought she was in the session was for the drop in grades, and maybe even exploring her going to some form of tutoring, maybe going with a friend that would also introduce that social aspect, find someone who you can enjoy going to tutoring with, and having her find some success in that area so she can start feeling better about herself.
It's nice because you tied it into both the academic achievement and the social and the emotion. Like do something that's going to help you get that goal of better grades, but also it's going to be pleasant. So that's a nice way to tie it together. All right, I'm not going to just do the front tables now. I got to get, because this is not church. All right, how about back here? Anybody want to give anything?
Well, my therapist was trying very hard over here. She was trying to get me from looking down and not, I guess the problem was in the hallway and transition times in school, I wasn't really feeling very good, and I couldn't say hi to people, even that I knew. So she kind of broke it down to, well, is there anyone at all that you would maybe, and I kind of grunted like, or she got me to maybe think about making eye contact to maybe saying hi. So she did a pretty good job. Now I'm talking.
Yeah, you're doing really well. You're even talking into the microphone, getting taped, it's everything. All right, so that's a good example too. Break it down into parts. And for a socially anxious kid, I mean, eye contact, saying something to people that are easy to talk to, even saying something to the therapist is a good way to break the goal down. Okay, and so you can see from this example that you may have a big goal of increasing social interaction, but you have to break it down more into something that can be done during the week, okay, and then count it. All right, how about you guys?
Well, I guess we didn't get too far, but basically we were trying to explore. I was a patient, and I was basically having a hard time getting up in the morning and getting ready to school. So my therapist was trying to explore if something happened, that I was afraid of going to school, maybe some underlying issues. I mean, now these days we see so much bullying going on in the schools, and the kids are afraid to talk about it. So we just got that far.
All right, so let's push it a little bit and say, if in this case you decided that, I'm going to make it a little bit easier, if you decided that it wasn't bullying and that it was more due to the depression itself making it hard to get up in the morning, what are some little goals you could create that dealt with that?
Maybe one of the goals should be the night before. The preparation for the morning, both in our self-talk and in our setting up your, putting your tools at the side of your bed, meaning your clothes or whatever it is, and discussing the sleep hygiene, having goals about that, because that may totally impact the morning.
That reminds me of something that we decided after the study was over we should have had in the manual, which wasn't in the manual, and that is the sleep hygiene stuff. Sleep hygiene being, how to get ready to go to bed, basically, and don't drink coffee 10 minutes before bedtime, and these kids do all kinds of things in their bedroom that they shouldn't be doing in order to help them sleep, like looking at a television screen or a computer screen right up until the moment they go to bed. That's really bad sleep hygiene. There is a list of, I mentioned this other manual, the Tassa manual, which I don't have, it's not out, but it does have sleep hygiene in it. And a lot of CBT manuals have sleep hygiene in them. We just forgot to put it in, basically. And we ran into a lot of cases where it should have been used. It was used, but it wasn't in the manual.
I was just going to say, I don't know if this is the intent of setting goals, but in our situation, so Mackenzie, some of her goals, obviously she was doing it intentionally, but some of her goals were a bit lofty, like, oh, I want to be an NBA player, or I want to do this. And I think you could really use the benefit of goal setting is that already tells you a lot about the child or the adolescent, and they're setting themselves up for failure, and perhaps that's their way of thinking of lofty thinking. And so you really learn a lot about the child or the adolescent just in how they construct goals. So I think it's really helpful.
And that lends itself to the cognitive work coming down the line. So, if your goal is to be an NBA player, which I always had as a goal, but it just didn't work out. I couldn't even make the high school team. It was kind of, at the goal-setting level, you can, I guess you could break that down into whatever it meant for them at the moment, like whether it meant to go out and play ball or practice or something like that. But then you would have to it sounds like you would have to get back to the cognitive part later, that the goals are so high that they're almost unattainable. Okay, one more, sorry. Can you tell us about your?
We were talking about a student that's depressed because they are always getting into trouble, getting referrals like once a week or two. And we talked about changing that. The goal would be to maybe one every 3 weeks. Yeah. Also, that would help the academic part, and also concerned with relationships. We talked about, when you're in front of a situation with another student, which is going to lead to getting the referral, stopping and taking time to think. Like when I work with kids, I don't tell them, with parents, don't tell them, take a time out. I use the word take time to think. It's like when you're going to get a citation as opposed to I'm giving you a ticket. So we use, words that, time to think instead of you're going to get a timeout. So.
Okay, so those are two good goals, and it reminded me of a case. I talked to somebody about this case the other day, and I don't know when it was, but I had this kid who came to me in about a year ago, and he had been hospitalized in the state hospital for a suicide attempt and possible mania. And this kid had been, he was about 17, and he had been hospitalized 3 times before. I guess I shouldn't think. He had been hospitalized 3 times before within the last 2 years, and he had been, kicked out of a school twice. And he had, multiple diagnoses. People had given him all kinds of diagnoses, and he was on like 4 medicines. So, when I got this referral, I thought, oh, geez, I don't know if I want to deal with this. This sounds pretty hard, And he came to me and he said in the first session that his goals were to get through the year, the calendar year, without getting hospitalized or getting kicked out of the house. Those were his goals. And, you know, he really stuck with them. And we did some work on sub-goals, one of which was think ahead, very similar to your stop and think. So he was kind of impulsive, so he didn't think ahead. So the sub-goal was when you feel angry or worked up, think ahead. And I just kept coming back to that in the treatment and coming back to it and coming back to it, and he learned it, and he succeeded. He's finished treatment, and he had a really good year. So for him, the goals that he himself set were really powerful. He really wanted those two things, and it guided. He was not, I would not say he was a kid in a major depression. He was more in a kind of a, I don't know, some kind of, he had ADHD and he was impulsive, and some people thought he had a mood disorder. But regardless, the goal setting was very helpful, and he was able to use it to keep himself under control, basically. Okay? All right, good. Any questions about goal setting based on what we just did, or? I know John Lockman talked about goal setting yesterday in his talk on aggressive kids, and he did a study. He's done this kind of study more than once, but in his original, his very first study of aggressive kids, he showed that the combination of cognitive behavioral training and goal setting was more effective than just cognitive behavioral training without goal setting. And the goals were things mostly related to classroom behavior. So I think goal setting is really important. I don't think you necessarily need to devote an entire session to it, but you might. It depends on how quickly you and the child can establish goals, okay?